Case, we have a 37 years old female diagnosed with multiple fibroids. The biggest was approximately 15 centimeter in diameter according to a recent MRI. The patient wished to pursue a fertility-sparing procedure to help manage her heavy menstrual bleeding and resulting anemia as well as pressure symptoms. Anemia may be corrected using preoperative iron and menstrual suppression using either gonadotropin-releasing hormone agonist or selective progesterone receptor modulator. In our case, the patient received preoperative iron and selective progesterone receptor modulator times 2 courses, each was 3 months long, to control her bleeding and to help shrink the dominant fibroids. Her hemoglobin increased from 70 to 100 grams per liter at the time of her surgery. The day of the surgery requires planning with the OR team, including anesthetists, nurses, and surgeons. IV tranexamic acid was given prior to the surgery. Before skin incision, the patient was examined and the uterus was found to be about 22 weeks in size. Our initial step was to enter the abdomen and survey the fibroids in relation to the ovaries, fallopian tubes, and adjacent structures. A midline incision was made with number 10 blade from the symphysis pubis to 1.5 cm inferior to the umbilicus. Using the ESU pen, the underlying adipose tissue and the fascia was incised and cut, and the abdomen was exposed. The uterus was then externalized through the laparotomy incision, and the fibroids were surveyed in relation to the adjacent structures. The second step in our approach was to secure the uterine blood supply with a pericervical tourniquet. To this end, the visceral peritoneum was entered anteriorly, and the bladder was dissected off the lower uterine segment inferiorly. Windows were created in the posterior leaf of the broad ligament on either side of the cervix, and a Penrose drain was passed around the cervix and tied tightly to act as a pericervical tourniquet. In this procedure, we used a Penrose tubing 3/4 inch times 1/2 inch times 18 inch long. Next, we aimed to secure the uterovarian vessels. Bulldog clamps were placed on the uterovarian ligaments bilaterally, thus minimizing the blood flow to the uterus. Care should be taken to avoid clamping the fallopian tubes as the patient wishes fertility preservation. The largest anterior fibroid was the first objective. 2 units of dilute vasopressin was injected under the serosa along the planned incision line. Repeat dosing was done every 25 minutes as needed. Using the ESU pen and a number 10 blade, an anterior sagittal incision was made just right of the midline. The fibroid was grasped with the tenaculum and shelled out bluntly and sharply with the help of the ESU pen. This was repeated for neighboring small fibroids using the same incision in the serosa. The endometrial cavity was not entered in these endeavors. When no further fibroids could be approached through the incision, it was closed with a 0 polysorb in 4 running continuous layers and a baseball stitch at the serosa with a 2-0 maxon. The same process was repeated on the posterior surface of the uterus to remove all the fibroids that were palpated. A total of 24 fibroids were removed at this procedure. The tourniquet was then cut and the bulldog clamps were removed. The uterus quickly reperfused and there was some bleeding from the incision site that was controlled with interrupted 0 polysorb sutures. Upon achieving hemostasis, the abdominal cavity was washed thoroughly with warm saline and suctioned. At the end, tab blocks were given at the level of the iliohypogastric nerve on either side, and the abdominal wall was closed by mass closure with 2 0 PDS sutures loop tied to each other. The skin was then reapproximated. 24 fibroids were removed and estimated blood loss was 100 cc's. No blood transfusion was required. In summary, our approach to minimize bleeding at a high-risk multiple myomectomy starts preoperatively with oral iron therapy to correct anemia, selective progesterone receptor modulator course to shrink the fibroids, and IV tranexamic acid before the surgery. Intraoperatively, we use Penrose band and bulldog clamps to secure uterine blood supply and subserosal vasopressin injection to minimize bleeding.